United States and Sub-Saharan Africa. She is principal investigator of the Adinkra study, controlled trial testing the effectiveness of a nurse-led mobile health intervention to improve hypertension control in Ghana, and the African Immigrant Health Study, a cross-sectional study examining the health of African immigrants in the Baltimore, Washington, D.C. metropolitan area. Next, we are joined by Dr. Marcella Nunez-Smith, who's the Associate Dean of Health Equity Research at Yale School of Medicine, She's also an Associate Professor of Medicine, Public Health, and Management. She's the Director of the Equity Research and Innovation Center, or ERIC, in the Office for Health Equity Research. ERIC's research promotes health and healthcare equity for structurally marginalized populations. Dr. Nunez-Smith is also the Director of the Center for Research Engagement, the Associate Director for Community Outreach and Engagement at the Yale Cancer Center, the Chief Health Equity Officer at Smilow Cancer Hospital, the Deputy Director of the Yale Center for Clinical Investigation, a core faculty member of the National Clinician Scholars Program, and the co-director of the Doris Duke Clinical Research Fellowship. Last but certainly not least, we have Dr. Gbenga Ogedegbe, who is a physician and who is Professor of Population Health and Medicine and Chief of the Division of Health and Behavior and the Director of the Center for Healthful Behavior Change in the Department of Population Health at New York University's School of Medicine. He is a leading expert on health disparities research, as his work focuses on the implementation of evidence-based interventions for cardiovascular risk reduction in minority populations. He is principal investigator on numerous NIH projects and has expanded his work globally to Sub-Saharan Africa, where he is funded by the NIH to strengthen research capacity and reduce the burden of non-communicable diseases. He has co-authored over 250 publications, and his work has been recognized by a number of research and mentoring awards. He has served on numerous scientific panels, including the NIH, CDC, World Health Organization, and the European Research Council. Welcome, doctors, one and all. This is an extraordinary gathering of expertise. I thought that, with the permission of the doctors, I thought that I would begin very briefly providing a kind of context for where we find ourselves on the 16th of October, 2020. And then, of course, I want to proceed to allow the doctors to speak. So as we speak, a third COVID-19 spike in the United States continues to intensify, with several European countries taking additional steps to reverse steep case rises, some of which are at record levels. Regarding the United States, as of yesterday, October the 15th, the number of newly reported cases surpassed 64,000 for the first time since late July. At least 216,000 people in the US have died of COVID-19 and the disease caused by the virus. As for Europe, Europe set a record this week for new coronavirus infections, overtaking the US in cases per capita. The World Health Organization says it is seeing, quote, exponential increases, unquote, in daily cases in Europe. At 1,000 deaths a day, COVID-19 is now Europe's fifth leading cause of death. In just the past 10 days, 1 million new coronavirus cases have been reported in Europe, raising the total since the start of the pandemic to 7 million, affecting France, the United Kingdom, Germany, Italy, Poland, the Netherlands, and so forth. With respect to Africa, the continent, which has a population of more than 1 billion, has had about 1.5 million cases, according to data compiled by the Johns Hopkins University as of last week. These figures are far lower, obviously, than those in Europe, Asia, or the Americas, with reported cases continuing to decline. Africa has recorded about 37,000 deaths, compared with roughly 580,000 in the Americas, 230,000 in Europe, and 205,000 in Asia. With respect to Latin America and the Caribbean, as of October 11th, last week, the region had almost 10.3 million confirmed cases, or 27% of the cases worldwide, with over 375,000 deaths, 34% of deaths worldwide, with Brazil, Mexico, Peru, Colombia, and Argentina with the highest numbers of deaths in the region, with Brazil having the third highest death toll worldwide after the United States and India. So that provides us with a brief overview of what seems to be happening in the world with respect to COVID-19. And so I would like to begin the conversation with our experts by asking about the general picture of COVID-19's impact on Africa and African descendant populations in the diaspora.
Great, I'm happy to get us started. You know, Dr. Gomez, thank you so much for assembling this panel. It is a great honor to be here with you and the center and my good colleagues, but we are not gathering for a happy occasion by far. I mean, the statistics you shared are sobering. And so I do think that gathering in this way and thinking about the diaspora is an important conversation that we need to have. So, you know, I might start by thinking about African descendant populations here in the US, right? So right now, at this moment, I'm situated in Connecticut. You referenced I'm faculty at Yale. I also have the honor of serving on our governor's Reopen Connecticut Advisory Committee and chairing the committee that is responsible to think about those populations who might be the most vulnerable. And in that category, we have to think about African descendant populations here in the state and across the country. And so back in April, with a colleague of mine, Dr. Carrie Gross here at Yale, states were beginning to kind of release this information. You know, you shared this information, it's great to have, but we didn't always have it. So I think there's one conversation we have to have today about data and the accuracy and quality of our data. You know, what is testing infrastructure? So we'll get into some of these topics, I am sure. But, you know, early on, you know, Dr. Gross and I, we were very, shall we say, concerned about some of the data emerging from states in the US that suggested that there was difference and a disproportionate impact on populations of African descent. And when we did an analysis and looked at age-adjusted rates, we saw that there was a fourfold increase for African descent populations in the United States for mortality from COVID-19, which, as you mentioned, is the clinical syndrome that is associated with SARS-CoV-2. 4 times. And sadly, that statistic has persisted. And as we see federal data release, it's still the same. Now, I'm sure we'll get into conversations too about kind of why we might see that. You know, many of the conversations that I have at the state and national level, you know, have to do with a lot of the social realities that are connected with intergenerational structural racism in our country, really driving a lot of that. But we have to be really concerned. So whether we have conversations about disproportionate representation in the jobs we've deemed frontline and essential, whether it's about multi-generational homes and crowding in neighborhoods, inability to adhere to any quarantine, isolation, or stay at home types of guidances. You know, I think we have to think of really all of that, as well as things like access to high quality healthcare, right? So I put all of that on the table for us to maybe explore a little deeper. You know, I also think a lot about the Caribbean and African descent populations in that part of the globe. And I'm principal investigator on the ECORN sort of initiative, which is the Eastern Caribbean Health Outcomes Research Network. And we have partner sites in the US Virgin Islands and Puerto Rico, Barbados and Trinidad, but really policy and stakeholder partners across the region. And we see quite the range in terms of what's happening in the Caribbean. There are several islands, I have them listed here on last count, I believe it's 7 as of yesterday, or 8, who haven't had a single COVID-19 death, not one. But then we see many other places where that is unfortunately not the case. So we see heavy burden in islands like the Dominican Republic, Puerto Rico, and many others. And we can look to things there like policy and closure of borders and who was able to and who acted when and who acted early and who didn't. So I think in our conversation today, I'm really quite excited to think about sort of all of this, around policy and the reasons why we might see range across the diaspora. But we know the burden, has been very heavy outside the continent. And I really am looking forward to learning so much from my colleagues today about this.
Thank you, Dr. Nunez-Smith.
Yes, so hello everyone. I'm Yvonne Commodore-Mensah. It's so good to be with all of you today. I just want to take a moment to thank our attendees for making time to be part of this conversation. And as Dr. Nunez-Smith mentioned, we are not here for a happy occasion. It's to talk about an important issue, which is COVID-19, that has touched so many lives. And I first have to acknowledge that there are folks on the call today who may have been impacted or may have lost loved ones. So I just want to extend my condolences. And I also want to acknowledge frontline workers who may also be attendees and have also lost colleagues or loved ones from COVID-19. So in terms of my interests, I focus a lot on the health of African immigrants in different contexts. So I got interested in this field because when I migrated from Ghana to the US and I took a cardiovascular disease epidemiology course, over and over again, I learned that Blacks were disproportionately more likely to have hypertension, diabetes, kidney disease, right? So you name it. Blacks were more likely to suffer from those conditions. So I asked myself, is this something about our skin color? That's not the case, right? There are a lot of factors that contribute to these disparities. So in terms of what we know about COVID-19 among African immigrants in the US, it's very little. And there are several reasons for this. Well, in the US, data on Blacks are aggregated, so regardless of region of birth. So on this call, we have Blacks who are from the Caribbean, Blacks from Africa, and we have attendees who are on the call who are Blacks who are born in the US. But the traditional practice has been to aggregate all of the data and classify Blacks as one race without acknowledging that there's heterogeneity in our backgrounds, our cultural beliefs, and our risk factors. So, but from the data that is available in New York, it provides a clue on the burden of COVID-19 on foreign-born populations. So we know places like New York have higher proportions of foreign-born Blacks. So you take an area like the Bronx, and Dr. Ogedegbe will be able to speak more to that issue. We know that those populations have more foreign-born Blacks or African immigrants or Caribbean immigrants than other regions in the US. So that provides a clue on the impact on COVID-19 on African immigrants. Well, if we want to learn more about African immigrants, we can also look to Europe. We know that in Europe, Blacks, Asians, and what they call BAMEs, Black, Asian, and minority groups are disproportionately impacted by COVID-19. So they're more likely to acquire COVID-19 and also have severe illness and die from COVID-19. And the reasons for these disparities are very similar to the conversations we've had in the US about social determinants. So Blacks and ethnic minorities are more likely to live in poverty. They're more likely to live in crowded neighborhoods. They're also more likely to be considered essential workers, right? And so these are all factors that increase the risk of acquiring COVID-19. But the question becomes in areas like Europe, where we know healthcare access isn't necessarily an issue, why are Blacks dying when they are hospitalized with COVID-19, right? So if you have folks who have similar access to healthcare, why are we seeing differences in outcomes? And I look forward to that discussion about how we may explain disparities in death and severe illness due to COVID-19 when healthcare access is not an issue, right? And the last thing I want to mention is that in Africa, when data started to come out about the number of COVID-19 cases, a lot of us were concerned, right? Because we know that our healthcare infrastructure has challenges. We don't have enough healthcare providers, and we don't have the medical equipment. So on the news, when we saw we saw people talking about ventilators and ECMOs, right? All of these devices that were necessary to keep people alive, right? So Africa doesn't have that luxury. So we were really concerned, but it's comforting to know that the number of cases isn't as high as was projected, but we shouldn't be comfortable because there are a lot of factors that explain the lower burden of COVID-19 in Africa. And that's another thing I'm hoping we can discuss, right? We shouldn't fold cross our legs and fold our hands and say, well, Africa is not impacted. Let's not address the healthcare infrastructure. Let's not focus on building the capacity of healthcare systems to address these issues. So at this point, I'll hand over to Dr. Ogedegbe, who will share his insights.
So thank you very much. And as my colleagues have echoed, it's a sobering moment, although we get used to it. As they said during the Second World War, when London was being bombarded, the feeling was that people were still going about their business, but it was being bombarded by the Nazis because everything became almost like a near miss. So in the context of a near miss, life goes on as usual, but there's just a lot going on. 200,000 deaths is not a joke. Even if it's only 37,000 deaths, as Professor Gomez talked about, it's still a lot. So I want to thank Professor Gomez for this invitation, thank my colleagues for joining us as well. And what I would like to share with you is the context in which this is happening in Africa, because then that can be a good segue into our next segment. So if you look at what's going on in Africa right now, I lost two good friends. My best friend in medical school, actually 3 years older, passed away from COVID. Ran a very large medical hospital as well in Lagos. And then my colleague, with whom I've worked for the past 10 years, the great Professor Jacob Landreau, passed away in Ghana. So we were both in Ghana. We have an NIH grant. He was the rector of the Ghanaian College of Physicians and Surgeons. And we're both there to do two things. We're running our studies. I was just there, I believe the last 2 weeks in February, came back here March 1st, and then we shut down the medical center March 7th. So I was with Jacob the week before, and he passed away on Good Friday. So why am I saying this? In Africa, a significant proportion of the cases are actually healthcare workers. And so the context in which this is happening in Africa is that there are three things to think about here. You have what we call the weak healthcare systems or weak infrastructure. We have healthcare workers. The ratio of healthcare workers to the population is very low. So there's a significant dearth or shortage of healthcare workers. So if you take a country like let me say Ghana, Nigeria, 1 to 5,000. Depends on where you are in Nigeria. That's 200 million people. If you take a country like Ghana, 1 to 12,000. If you go to Namibia, 1 to probably 100,000. That's a physician. So you have these shortages where Africa currently has, of the global burden of non-communicable diseases, let's say about 14% of that burden. We have only about 3% of the workforce. So that brings me to the third aspect of the context. There's a rise in the prevalence of non-communicable diseases. And what that means in simple person's language is hypertension, diabetes. We're seeing more cancers than we used to see. And then mostly respiratory illnesses, which is very important to think about. And number one killer of deaths in children, ages 1 to 5, the highest rate of mortality is pneumonia, and that's in Africa, followed by India. So you can see the biomass and the environmental exposure and pollution So all of that context is the context in which the COVID pandemic hit Africa. The last context is urbanization. So most of Africa today, there's rapid growth of urbanization. 56% of most African countries actually is in the urban. We call it the peri-urban. And why is it peri-urban? Because most of the urban areas are very well developed. They have the right infrastructure for, if you may, for, for the water system, the electric system, the sanitation system is robust. The peri-urban areas are areas that grew significantly. So Lagos is the size of New York City. And we have, just within Lagos itself, that's where I grew up, it's 12 million people. If you look to the outskirts, 22 million people. I laugh when I'm in Ghana to say that we can fit the entire population of Lagos into Ghana. And so my Ghanaian friends, they say, what do I mean? But just imagine that density that I'm talking about, the size of Texas, Nigeria, 190 million people. Lagos, a very small place, has a lot of people. So that is the context in which this is happening. The question then becomes, what is driving the disparate burden that we're seeing in COVID? In my mind, and I'll see what my colleagues think about this. In my mind, I think two things are happening here. It's a tale of two different kinds of continents. North America, Europe, and then we have Africa. We're not going to talk about South Asia because they've been living with this kind of issues for a long time, and they've done a good job of their public health messaging where people wear masks. It's standard for them for some reason. It's something foreign to us. If you look at the tale of the two continents, immigrants in America today, at least of African descent, they cluster in the urban areas, right? They cluster in those areas that are hardest hit by the pandemic, right, over here. So I would argue that what you're actually seeing is a reflection of what happens to immigrants of African descent here is what is happening to African Americans and Hispanics here as well. So I don't see a difference there. In fact, it depends on where you are. So if you come to New York City, you want to know where the Jamaicans are, go to Flatbush. Michael, you know this well. You go to South Bronx, where you see a lot of the Ghanaians. Nigerians are everywhere. Liberians, Staten Island. So you can begin to track really the epidemic of what is happening in those communities as well. We have friends who lost their friends, nurses from West Africa, Ghana, Guinea, and again, that's where they live. So the second thing to then, in my mind, is the tale of these different continents show that in the US, the structural factors that drive racism, actually, of structural consequence of systemic racism unveils itself, where we're treating people differently. In Africa, with all of the bad stuff you can imagine, sometimes I wonder when we read grants and we're writing all the bad stuff happening in Africa, I'm like, how come it hasn't been wiped out yet? Why is it still, most of the countries are still doing well? Well, because people are not treated differently. Other than socioeconomic status, and COVID has said, in fact, in Nigeria, most of the deaths that we saw, healthcare workers and really people that are affluent. Why? Because the affluent folks are the ones that travel a lot. And when you travel, they come back into the country. It just so happens that there's some level of segregation there in the sense of how do you mix with the community? And so they had to quarantine. Most households are multi-generational households for the most part, but with affluence, we're beginning to see significant amount of segregation in terms of where people live and how they live. So I think that those are the contexts we have to appreciate. You don't have that there. But I will stop for now. There are other things we can begin to think about, but that is the context that we're beginning to see. The good news is that it's not as bad as was predicted. We thought there would be 300,000 deaths in Africa. It didn't happen. That's on the good side. On the worst side, people are saying maybe about 1 million deaths. Didn't happen. We thought there'd be about 1.2 billion infections. Didn't happen. There's a whole host of reasons that we probably will get into trying to unravel this.
Thank you.
And if I may,
yes, please go ahead.
If I may piggyback on what Dr. Ogedegbe said in terms of why it seems that Africa has been spared from this pandemic, I think it's important to acknowledge that of the populations with youngest persons, Africa has 19 of the 20 youngest populations in the world. So when you think about the age distribution in Africa, most people are fairly young. We have old leaders, but the population is fairly young. So in the younger population, you have a lower prevalence of hypertension, diabetes, although, as Dr. Ogedegbe said, a lot of these non-communicable diseases are rising. When you compare the age distribution of the African continent to a lot of regions like Europe and the US, we are relatively younger. And we know that in the US and in Europe, most people who have died from COVID-19 have been the elderly, right? So in a way, that's one of the things that has worked in our favor, which is that people are younger. Yes, we've had some experience with previous outbreaks such as Ebola. So although our healthcare infrastructure is weak to some extent, we have some experience with handling outbreaks. So our public health infrastructure, I might argue, in many ways may be better than some regions in the US, right? Sometimes I like to say the US is a developed country with third world regions in the same country, right? There are under-resourced, under-serviced areas in the US where you have life expectancy that is very similar to African countries. So I'm glad that the burden of COVID-19 hasn't been as high as was projected. And frankly, a lot of us were alarmed because we feared for our families back home. And Dr. Ogedegbe, I'm sorry for your loss. I know you were close to your colleague in Ghana, but a lot of the deaths have been in healthcare workers. So when you think about the fact that pre-COVID, right, there weren't enough healthcare workers to manage our healthcare needs. Until we ensure that resources are provided to protect these healthcare workers, right? In the next few years, we are going to see another public health crisis, even after we resolve this COVID pandemic and a vaccine is obtained.
Yeah.
Sorry, go ahead.
I just wanted, just one sort of quick point to follow up, and yes, Gbenga, my sympathies as well. And but I think this point about the public health infrastructure, cannot be overstated. I had a chance to speak with a forum of African women's leaders earlier this year, and we were having a form of this conversation because at that point the numbers were already lower on the continent, and we were in the midst of just calamity, really, here in the U.S. And they raised the point of saying, we have a very robust network of community health workers, and so this ability to sort of be out in community, helping to navigate, to do outreach, to test, and then the tracing and the ability to support people in that quarantine and isolation. And so some public health 101 fundamentals that I think have been revealed most certainly in the United States. We just did not have that workforce in place. We did not have that training ready to go. And our testing and tracing strategies have been very delayed and incompletely executed. And so really important as we compare kind of where it's the same in the Caribbean, where we have a fragile healthcare system. But in contrast, you might see some assets and some strengths in public health.
Yeah, I wanted to follow up on that, Dr. Nunez-Smith, because I think that I just wonder about that. We have this, the disparities between rates of infection in the continent and those in the US and Europe in particular, and Latin America are pretty astounding. And I don't know that I've run across any group or any agency that is saying, oh, well, maybe we need to go and study what they're doing in Africa to learn something. I haven't read anything about that. Am I missing something, or?
I see my colleagues all sort of shaking their heads. No, but this notion of kind of the global health advantage, I mean, that's been around, right? I mean, back to the point, that Yvonne made, that there are, when we look at some of our vital statistics in the United States, things like infant mortality, we lag. We perform worse when we think about infant mortality for African descent babies in particular, right? We lag many of the countries we would call developing and third world. So we see these statistics, and I think there are many, I think for us on this call, there are many of us who have long said we can learn more, right? But if only we could reorient ourselves to that posture, to a learning posture, to understand better from other places. That is an excellent point, right? And I take that example of the community health workers just as one case, right? I mean, to see these leaders, incredibly impressive, to see the really outpouring of sorrow that they expressed for the situation we find ourselves in the United States. And to say, but there are solutions that are not so expensive. The solution isn't always a ventilator or ECMO, right? We have missed. For us to need those resources means we have missed many opportunities to that point. And so I completely agree with you. And to those people listening, say, yes, we need to do more in terms of humbling ourselves to learn from our neighbors across the globe.
So let me try and chime in here for to address the same question. Why aren't we hearing much from people? But suffice me to read a few things to you. So there are 4 issues that people have said is driving, maybe 3, driving why there's such different epidemiologic data from Africa and other continents. So the lockdown was pretty swift and very quick, and was really serious. It was like, if I didn't leave Ghana on the 28th of February, I'll have been stuck there. So the lockdown was quick, and the closure of the borders to minimize travel was also very quick. But the key factor is what Dr. Commodore talked about: well-coordinated public health strategies. And those strategies actually leverage what was already happening in terms of the infrastructure that were put in place after the Ebola epidemic. And I think one thing that is often not talked about enough is the fact that, Africans innovate a lot. Think about it. You're talking about 56% of the area is urban or peri-urban, which means there's no way for you to do social distancing. But because you've locked down the economy and the system, they were able to continue the social ties, but to also protect the elderly. Remember, unlike here, most of our elderly are in nursing homes, right? Or assisted living environment. There, everybody's home in the same area. People have argued that, well, maybe it's because they have the village life and they can distance in the villages. Well, that's not true. The cultural factors of outdoor village life, it's only about 30–40% of the area. Majority of the places are actually urban and peri-urban. Others have argued that, is there some genetic or pre-existing immune protection? And the answer is no. This is where we begin to look at policies to want to blame the individual for what is happening. It just won't work in this case. It's worked for malaria. It worked for tuberculosis, where we didn't talk about the environment, talk about the people. It's working for hypertension in Blacks in the US here, where we don't talk about them, where we talk about the people. But the answer is no. We haven't found that biologic mechanism. If we found it, then people of African descent in this country should actually be protected, right? If you think about it. Some say, well, it's a different and a weaker virus strain. But the issue there is that when you look at that argument, yes, people haven't done enough testing. But when you think about it, the viruses and the genetic makeup and the strains that they found in Africa reflects the same strains that was causing the grief that we're having now in the US as well. And others have argued also that, maybe because it's higher temperatures. Well, we know that's not true as well. So you have all of these things that have been proposed as reasons. I think the reason we don't talk about this is just the issue of racism. Globalization, colonialism is the grandfather of racism. Let's not get it mixed up. So when you look at colonialism, it's always have to be a deficit mentality. There's something wrong with the Africans. And the only time the Africans got it right, we don't know who to blame anymore. We're going to say, you know what? Let's not celebrate. Let's not pop the champagne bottles yet, because we really think there's something there. People are postulating, there's some truth in some of these, that, you know, maybe there's a chronic exposure to infections. So that is why the activation of their immune system that's supposed to protect us is less dramatic, as it is for those of us here. Okay, so how do we explain malaria if that is true? So, you know, these are the kind of things you would never hear about, but Dr. Nunez is absolutely correct. The public health infrastructure, I mean, think about it. The only way you really survive in these low resource settings is to have a very rigorous, well-oiled public health infrastructure. We heard of the Ebola case. I was actually in Ghana, went to Lagos briefly for a day, and on my way out, when we had the Ebola episode in Lagos, I mean, the swift response of the Lagos State Department of Health was incredible. And it's still a joy when you talk about this thing. It's the same strategy that was taken to Liberia over time, but we don't talk about this coordinated effort. Africa CDC was set up by President Obama after the Ebola epidemic. Africa CDC was meant to coordinate every aspect of contact testing, tracing, and tracking, right? And that's exactly what happened. People will say, what about the testing? Well, guess what? If you look at the absolute number of testing, it seems as if it was less. But if you look at the testing per case, Africa was on par with other continents. If you look at the testing per case for each period, it was still on par. So we can't simply explain this away, other than say that the public health infrastructure did what it was supposed to do. And unfortunately here, we haven't done a good job of that.
Dr. Ogedegbe, I really appreciate that, because I tend to agree with your analysis in terms of the reasons for this. There's a kind of conceit in the West with respect to Africa, and the assumption that, you know, the West needs to bring gifts to Africa in order to straighten things out, and that you know, the assumption was that the disease was going to be horrific in the continent and so forth. And it's just astounding that there's been nothing that I have seen in which scientists have said, you know, we really need to go and find out what they're doing in the continent so that we can, you know, replicate that. But the other thing that I've read about, and I'm curious to hear what the doctors have to say about this, is this business about climate. And temperature and humidity as potential explanatory factors, because you will recall that when this thing first broke out in Europe and in the US, the thought was that, well, when it gets warm, this is going to die down. This is what our political leaders were saying to us. Now, all along, you know, I'm looking at what's going on in Brazil, which was already warm. And, you know, the numbers were going through the roof in terms of rates of infection. So it never made any sense to me. I wonder, could you just address that? Because here you have a situation like Brazil, which is third, or India, second and third in the world in rates of infection. And I know that the climate changes, in particular in Brazil, but these can be very, very warm places, and yet you don't have these rates in Africa. So should we just completely dismiss the issue of climate and temperature and humidity? I mean, these are these non-factors. Can we just take those off the table?
I look to my colleagues. I don't want to talk too much, but I think yes, we should take it off the table. Totally. I mean, we know so much more now, thank God, and I think we're treating people faster, but we still have a problem. It's all about public health. Look, virus infections, we talk about two things. Our prevalence will be epigenetic. So there's something about our inherent immunity, but there's something about the environment. So I think the weather will fall into that whole aspect of environment. Remember, there was malaria in the US too, okay? Bad one too, right? Maybe a century ago, maybe 50, 60 years ago. It was all about the environment. You clean up the environment, things disappear. People said there was some disease that was kind of inherently African. We just haven't seen that yet. So with the virus, it's the same thing. It can last on surface for hours, but we're learning more and more that is from droplets, and we've vacillated a lot, even on that notion itself. But I think we know much more about it than we used to know. The weather has not made a difference. Of course, there's climate change. Everything is, God knows, all over the place now. We still have some deaths. South Africa was very well. It was hit pretty heavy, unlike other African countries. And my own theory for that is that, I don't know that they locked down on time. Is a settlers colony. So if you think about what I mean by that, is that for most of the African countries is where a lot of Europeans actually live. People don't go to live in Nigeria or in Ghana for that matter. Maybe Ghana opened the doors now. We have the homecoming that happened last year. People, East Africa, South Africa, is settlers colony. So the transportation and the movement of people between Europe and South Africa was intense. That's my theory. I could be wrong. So, but it was also hot. So what happened there? So I don't know that theory works actually.
Right. I mean, I agree. I think, we have enough evidence to know that that's not the theory. There certainly are behaviors that are associated with increased viral transmission, right? Being inside, kind of the quality of the air circulation, the filter. So anything that drives people sort of inside and in close proximity, especially when, we're not masked and other things, is going to increase viral transmission. And it's true that as temperatures drop, people are going to move inside. So there's some of those behavioral things I think that we could associate, but climate in and of itself, absolutely not. But I'm really grateful you raised that, because this idea of the misinformation and the disinformation campaigns that are out there, I think is, part of the narrative. I myself am not on social media deliberately, but people are often sharing with me things that are posted that are just wrong, about SARS-CoV-2, about COVID-19, about things that we know help. A lot already coming about misinformation regarding the vaccine. So, I put this in that category of a threat to our health, really. Misinformation, disinformation, some of it really deliberately disseminated. And I know that's something that we just have a huge problem and challenge to overcome, is making sure people have accurate information, to make sure that our messages are clear, to make sure that we are identifying trusted messengers. And that has got to be continuous work that we do. We really have to be proactive in counteracting the false information.
So let me build on that. I lost my train of thought. So Michael, if you look at the HIV epidemic, right? 75 million people in Africa, right? Was really bad. But you know what really happened? All of that happened in the context of what I said earlier on: weak healthcare system, low healthcare worker to population ratio, and what we call the rising burden of non-communicable disease, where you then stress out the infectious disease folks who are working in that space. But you know what made a difference? A concept called task shifting. So we're shifting tasks from the physicians to the non-physicians, and they did it so well that the market woman can actually activate how people can get their HIV medications. Now, those are the innovations that we're beginning to want to adopt here now. And we call that reverse innovation, taking what has worked over there and bring it here. So all of those things, if you overlay the COVID pandemic on that, there's some robust system in place right to address that. And PAHO, which is a lot of folks that Marcella has worked with before, the Pan-African Health Organization, they've taken that stuff to another level. And that's the only way you can survive as a healthcare system without resources. So again, it just proves the point that we've got to give the credit where the credit is due. Now, Mexico, Brazil, India, these are systems that are beginning to become much more westernized in how the healthcare system is being driven. But we cannot forget the issue of age. The median age in Africa is only about 15 years or 18 years. In the US, maybe 40 something, Europe, maybe 30 something, or vice versa. So we, Puerto Rico will be probably about the same. So age matters in this case. It may explain some of the variants we're seeing, but we cannot ignore the public health aspects and the behaviors that we just talked about.
Well, can we just take a little, can we drill down a little bit with respect to some of the, with respect to what's happening in the continent, because it appears that that South Africa is a bit of, is very much of an outlier. As of, it's like it's ranked 11th among the nations in rates of infection. There are nearly 700,000 South Africans who have been infected with the coronavirus, and that's out of a population of over 59 million people. It's about 1.1% of the population. So that's rather significant. It's kind of on par with Dominican Republic, because Dominican Republic is about over 120,000 people who have contracted coronavirus out of nearly 11 million people. That's about 1.1%. So I'm trying to understand, as a layperson, what's going on in South Africa. Dr. Ogedegbe, you've alluded to one of the reasons with respect to, the demographics of the country. I'm wondering about that because I'm looking at that in relation to Egypt, which also has a very high incidence. Although Egypt's incidence is 0.1%, South Africa is 1.1% of the population. So, given that, relatively speaking, the continent is I don't know, can we say it's doing okay? We're not relaxing, but it seems that the continent is doing okay. Europe and the United States are about to go through a second or third wave. I don't know what the proper characterization of it is, but we're having a hard time on this side of the Atlantic, that's for sure. So what lessons should we learn from South Africa? What things should we avoid going forward?
Yeah, so maybe I can disclose this now. So I'm a member of the Academy of Medicine, and I had an opportunity to actually, we're looking at some data where the issue I think that came up with South Africa was the issue of, and it wasn't just South Africa, it was I think Kenya and Nairobi too, was the issue of the public health messaging. So the same confusion that we had here in the early days where, wear a mask, don't wear a mask, all of that was happening there, playing out heavily. I think in terms of locking down, they came to the game much later, unlike the other countries. So I would like to see, this may be a conspiracy theory though, but let me quickly admit it first. I would like to know what the proportion is of South Africans that died, okay? How many are Black South Africans, how many are white South Africans? I say that because if you look at a lot of the places where we're seeing all these top deaths, there seem to be some racial disparities or ethnic disparities in terms of how you look at it. But I think the travel, and there it may be the opposite so there's a mistrust. I think true for most African countries, but probably much more so there and East Africa. And the distrust there is that people don't believe the public health messaging they're getting. And so the idea of locking down, maintaining strict borders, I don't think it played out well. Same is true in some part of East Africa. In Nigeria, it was not true. When they just clamped down. Ghana was even worse. They just clamped down, period. So I wonder if that's part of the issue. That may have played a role. But I think the travel ban also, South Africa is the hub, right, for most of the economies with Europe. And so I think there's a lot of traveling happening about the same time. And once you catch it earlier on, the problem is difficult to contain without a solid public health program in place. That would be my thinking for a while.
Thank you, Doctor. Well, what's going on in the Caribbean with respect to, we have this, the Dominican Republic has over 120,000 folk with COVID. That compares with Cuba, which reports just a little over 6,000. They both basically have the same population. So what's going on with what's going on there? How do we explain the divergence?
Yeah, so very similarly, across the Caribbean, we're seeing variation in terms of impact and effect. And, a lot of this, again, the points about policy and public health infrastructure and messaging and action really cannot be overstated. In particular, we're looking at islands, right, which is large. That's what we're talking about in the Caribbean. Thinking about islands, the management of the border, right, is going to be critical in part. And so you see, for many of the Caribbean countries who took that early swift action, right, that's the theme that emerges. And, places where the actions were early, were very consistent, where folks believed and adhered to the public health messaging, right, and had really the supports to do so, we see better outcomes. And so we have many islands in the Caribbean that I mentioned that, thankfully have yet to have a COVID-19 death, right? And have a whole list. I mean, Anguilla and Grenada and St. Barth, just many places, in deep contrast, right, to Dominican Republic and other places. And, we've talked a lot about things like the relevance of, social structure and dire poverty and what that means and really what one's options are and are not for being able to adhere to the messaging. So you have to have all the pieces in place. You need that strong public health infrastructure that's ready to go, right? That task shifting, like we talked about, those community health workers, people to get out in advance to test and trace. But then once you do that, you have to also be able to support people so that they can adhere to the recommendations. I know even in the United States, we were saying wear a mask, and we can have another conversation about the controversies and inconsistencies about the messaging, but people don't have masks. So are we providing the mask, right? We want you to stay home for 10 to 14 days. Are we making sure that you have the food you need so you can remain home? So are you making sure that you can separate yourself from your family members in these multi-generational households? So all of these, really, you have to be just very stringent about following kind of these protocols. But I think the same explanation across the continent is why we see what we see in the Caribbean, sort of just different approaches, perhaps in terms of the capacity to close borders. A lot of our work is in the territories, and the US territories in particular, they don't have control. So USVI, Puerto Rico's rates are very high, both those places, but they don't have the autonomy, right, to make those decisions about closing the border. So you see differences there as well.
Wow. Mm-hmm.
Right. I wanted to touch quickly on a point Dr. Nunez-Smith made about distrust and messaging. And as we all anticipate an effective vaccine, I think an important conversation that we should have is making sure we address the issue of trust or lack thereof when it comes to an effective vaccine. So there was a recent poll by the Kaiser Foundation that showed that among African Americans that were surveyed, about 49% of them said that they would not take the vaccine, even if it was found to be effective and it was free, right? And of all the trials that are ongoing, the over 33 trials that are ongoing, the question we have to ask is what proportion of participants are Black or of African descent, right? So there are 2 trials that are ongoing right now, and they are in South Africa. One was a phase 2 trial and another was a phase 3 trial. But we need to make sure that there is sufficient representation of Africans and the African diaspora, because that plays into whether or not people are going to trust that the vaccine will be effective when it becomes available. And Africa has traditionally been sort of a passive consumer of vaccines. So down the line, as we think about how we may plan for the next pandemic, God forbid, we also need to think about ways that we may innovate so that vaccines are developed and tested primarily in the African region, right, to ensure that it's effective for the population, and we're not necessarily importing a vaccine that is tested primarily in one population, and the assumption is that it's going to be effective and work for all. So these are issues that people are thinking about, and so I think that as public health practitioners, researchers, scientists, we need to think about how we can ensure that we address issues surrounding distrust when it comes to vaccines and research in general. And I'm glad you brought up that point about the Caribbeans and that context. So even as in the US and across the world, we all await this vaccine, I think we need to do some work to address these issues.
Dr. Commodore-Mensah, that's you certainly put your finger on, I think, is a genuine conundrum when it, as it applies to African descendant communities, because we know the history of this, and we know that African descendant communities in this country as well as in Africa have been used in scientific studies in ways that were actually detrimental. We know about the Tuskegee experiment and so forth, but there are other examples of this during the colonial period in the African continent and so forth. Not to belabor the point, it is simply that there is this distrust, and it has not been, I think that distrust has been exacerbated by the current political climate in which we have a leadership which has politicized everything. And so you have this history of mistreatment combined with political leadership that is not telling you, is not providing you with accurate information, and is in fact misinforming the public for political gain. So you are the leaders, you are the scientific leaders. What are what strategies? But I understand what you're saying. I think that what you're saying is exactly right. You have to have Black people involved in these studies in order to get it right. So how do we, what are the strategies that we need to adopt in order to overcome all of this distrust?
If I can briefly discuss one or two, and I'll ask my colleagues to chime in. In addition to ensuring that there's sufficient representation of Africans and African descent populations, I think we need to engage community leaders who are respected voices in the community. We need to engage them throughout the process in terms of health communication too. There are different avenues. When you think about Africans or the African diaspora, we come from collectivistic cultures where, whether it's through faith-based settings, community groups, we like to stick together, right? So finding trusted leaders in these groups to help with messaging, public health messaging, communication, and we also have to be careful about who we're sending out into the community, right? So with research teams, one of the concerns is often we have research teams that don't reflect the population that's being studied, and that's why I've always admired the work of Dr. Ogedegbe and Dr. Nunez-Smith in terms of being from the diaspora, but also engaging in work in the Caribbean and in Africa, so that when you go, people understand that you're there to help improve the health of the population. You understand the context, you understand the culture, and you invest time to make sure that there's buy-in, and you're not just going into these communities to collect data and leave, right? You have a strong investment in the health outcomes of the population. So engaging community leaders is one of these strategies that I would I'd like to suggest. And another is ensuring that in terms of public health teams, research teams, that we ensure that there's diversity in the composition of these groups.
Yes, I can add and piggyback, and I mean, just stated so well, right? The importance, the imperative, really, there's no other choice, and shouldn't be, no alternative to engaging community, but also in that how. So I really like that you discussed that process, right? And the importance of that. You know, what I would add to that conversation is that we need to take politics out of vaccine development, right? Period. And there is no, this is what is undermining trust too for everyone. The statistic from Kaiser Family Foundation is correct. The rest of that is that the general public, right, just all comers have a high degree of vaccine concern, right? We already know that the vaccines are being developed faster than other times in history. And scientifically, we can explain why, right? All the resources that are being put in, that is not of concern. And I spend a lot of time going to groups and saying, look, the rapidity of development is really not the concern if we are sticking to everything in the protocols that we have. And so, you know, we shouldn't underestimate people's understanding, right? When we have folks calling for arbitrary dates of vaccine release that don't coincide with when we have the data we need to make determinations, that raises concern for everybody. And politicians should not be in the business of deciding when vaccines are ready to go or not, right? That's for the scientist. And so, you know, I am very rarely a sort of rising tides lifts all boats. That is not my philosophy in terms of addressing disparities in health equity, but I'm saying there are general concerns. And I think that for people of color who have really, I mean, real good reason. We often don't always say that, right? All this distrust of healthcare systems and research is earned. We, the researchers, have earned this from all of the misdeeds of the past and the not so distant past. So I think people of color are able, these are the things around the dinner table we talk about, right? Things like Tuskegee and others. So they can more quickly see when a process is raising concern. But we have to get ahead of this and make sure that, you know, we call for, and as scientists and researchers, we consistently call for politics to get removed from science and from this vaccine development process. And so I would add kind of that policy piece to everything that was so well said about community engagement.
So let me give you some good news quickly. I know we have to run. So the good news here is that the National Institute of Minority Health and Health Disparities and the Heart, Lung, and Blood Institute actually thought about this, and I'm sure they couldn't do much government-wise, and they came up with something called Community Engagement Alliance Against COVID Disparities. And basically what they did was funded, I think 11 scientists groups from the top countries that were experiencing the higher rates of prevalence: Alabama, Arizona, California, Florida, Georgia, Louisiana, Michigan, Mississippi, North Carolina, Tennessee, and Texas. And the idea really is to do exactly this. And hopefully, I'm acting as the co-chair of that work group to help them think this through. They're doing a series of needs assessments in the community. What I'm telling them to do is also reach out to the immigrant community as well. And we'll see how that goes. But that's the kind of work you need before you can start talking about the equitable distribution of not just the vaccine, but really the representation of folks who are disproportionately affected in that as well. But at least they're doing something. We'll see. We're trying to say, make it as fast as you're making the vaccine as well. But to build trust in community, you can't go too fast. It takes
and
time.
You can't start now, right?
You can't start now. They're all asking, where were you during the COVID pandemic when it was hitting us hard?
That's right.
Where were you when we were in the soup kitchens? Where were you? That's what we hear in New York City. It's tough.
That's right.
Well, doctors, this has been extremely informative. We want to move toward a conclusion. What I want to do is to present to you a couple of questions, and I would ask that you, as you determine, respond to them with some brevity. But you know, we're all wondering, how does this pandemic end? And you know, what level of efficacy should we expect out of these vaccines? And you know, what measures are being taken so that to ensure that these vaccines and various therapeutics are as available in Africa in the Caribbean, Latin America, as we know they will be in the United States and Europe?
I speak briefly to the issue of the African context. So the Africa CDC, together with the African Union, has established a fund, and that's supported by the Bill and Melinda Gates Foundation, Result to Save Lives. There are other organizations that have committed funds to ensure that the vaccines are widely available to Africans and are hopefully free or fairly affordable. So I know that that fund was established a few months ago. So when an effective vaccine becomes available, will be important to see how it's distributed, right? So the African continent includes 55 nations, AU nations. So it will be interesting to see how the distribution occurs, right? We know that some countries have been hit harder than others. So the equitable distribution of the vaccines would be something that I would like to see in the near future. But I do know that a fund has been established to address this issue in Africa.
Dr. Commodore-Mensah, before we move on to your colleagues, you just identified something that I hadn't really thought about. I was thinking about equity, between Africa and the rest of the world. But you raised an interesting issue, and that is to say, how is this thing going to be distributed within the continent? I would imagine that those conversations need to be taking place right now. And is that going to be in conjunction with the African Union, or how does that? What is the mechanism for determining that?
I wish I had the answer to that specifically, but I do know the AU is working with the Africa CDC to make that happen. I'm not aware of the strategy or how that determination is going to be made in terms of who gets it. Are they going to look at the proportion of cases, the case fatality rate, all the variables that you're going to factor into who gets it and how many vaccines are available? But I think ideally the vaccine should be available to all so that there isn't like competition between regions like, let's say, South Africa, that you would argue that they may have more political power, right? When you compare them to small countries that may not have as strong as a strong voice in a lot of these political spaces, right? So I think equity is absolutely essential, and I hope that strategy is clearly communicated.
Yeah, I would just briefly add, to this idea that there are these conversations happening now around the globe about vaccine prioritization, right? Some happening with the WHO, and certainly in the United States we have the national academies and others weighing in. But this, we see more, I think, interest and investment in this question that you asked, Professor Gomez, around equitable distribution. We have Gavi, these global alliances that think about vaccine and vaccine equity and distribution. And the reality is in everyone's best interest for us to get this right? Because as long as SARS-CoV-2 is roaming anywhere, it's roaming everywhere, right? And so this notion that we can somehow bubble ourselves tightly enough by hoarding vaccine for one, high wealth country versus another, it's false. That's a false premise that will keep us safe. Your questions about things like what level of vaccine efficacy we're looking at are probably beyond the time that we have left, because there are different equations and permutations about how many people need to be vaccinated depending on things like the efficacy of the vaccine. But just really importantly to say, we have several vaccine candidates that are in play. And I think our ideal scenario is that there are multiple, right? Just not just one, but that there are multiple vaccines that are available to help us fight against SARS-CoV-2.
So should we anticipate that that the world will be in a better place by what, summer of 2021, or what is the?
You sound like a politician. Look, oh, I'm not going to name who. Look, pandemics have been here before. Are we going to the extent that we move around as human beings, we really need to take this even more seriously on a longer term. I think life as we know it will not be the same in terms of whether we wear our masks or we go around our places. Vaccine is not a magic pill or shot for that matter. Whether we have a vaccine or not, COVID is not going anywhere anytime soon. So what the vaccine does is at least it helps to prevent, right, the number of cases that we're having. It doesn't mean it goes away. We still have to do the basic things, which is all individual behaviors for the most part, I would think. If I was a public health specialist right now working with governments, I will continue to hone in that message that it's important for us to do our social distancing and continue to test aggressively so that we can better know what the community level of infection rate is like they're doing in some schools, including NYU right now, for us to be able to keep tracking people until we figure out a way for us to have a better way to readapt our lifestyle to that. They're doing that in Asia right now. Everybody wear masks. They've been doing that for a decade, at least, that I remember. So I think the notion that once the vaccine comes, everything disappears, that's not going to happen.
Well,
everybody get your flu vaccine.
Yeah, and we should get our flu vaccine right away. Thank you. I need
Yeah.
to tomorrow.
Yes. Well, this has been certainly enlightening, and I want to thank Drs. Yvonne Commodore-Mensah, Dr. Marcella Nunez-Smith, and Dr. Gbenga Ogedegbe for your time. You are extremely busy individuals, and we are just so appreciative that you've taken just a moment or two out of your busy schedules to share with us this important information. I want to thank all of those who have who are participatory in the session, and this is being recorded, and we will make this available in short order on the Center for the Study of Africa and the African Diaspora website. So once again, I want to thank our esteemed panelists. I want to thank everyone for your presence, and I want to wish everyone a safe and productive weekend and immediate and extended future. Thank you so much.
Thank you.
Thank you.
Thank you. Bye.
Thanks, Marcella. Thanks, Yvonne. Nice to see you.
Great to see everybody.
Thank you. Take care.